Good evening, everyone. Am I audible and visible to you guys? Just update me in the comment section. Yes, perfect. Welcome to the session, guys. So today we are going to have a discussion about PSM, and we are going to discuss the same way we have discussed the OB-GYN. We'll solve some questions, and followed by that we are going to have a deep discussion about those topics. Is that clear to everyone? Yes? Chalo. So be interactive, keep answering. Okay, PSM is a scoring subject as well. So let's try to answer and make this revision session interactive. Okay, so without any further delay, let's begin with the first question. That's from the chapter pneumoconiosis. The first question is, a 47-year-old man presents with a progressive shortness of breath. So patient is coming to you, 47 years old, having a complaint of shortness of breath. Patient is complaining of shortness of breath and a history of working in a quarry for 20 years. So she's working in the industry for 20 years. The chest x-ray shows the multiple small nodular opacities, predominantly in the upper lobes. So the chest x-ray having opacities in upper lobes and hilar lymph nodes, and the hilar lymph nodes have a eggshell calcification. Again, a catch point. A patient is coming to you with a complaints of a shortness of breath and a history of working in a quarry for 20 years. Chest x-ray have a nodular opacities over there, and they are usually in which lobes? Upper lobes. So upper lobes. Along with that, there is a calcification in the hilar lymph nodes called as which calcification? Eggshell calcification. What is the likely diagnosis? Comment down the answers. What is the likely diagnosis? Excellent. The likely diagnosis is going to be the silicosis. Now let's understand what all about these pneumoconiosis. Now what exactly are the pneumoconiosis, sir? So the pneumoconiosis are the respiratory disease. They are the respiratory disease occur due to exposure to dust. Now we are going to discuss about the different types of pneumoconiosis and the associated dust and the classical features of these pneumoconiosis. Now if I talk about the first one, that is going to be silicosis. If I talk about the first disease, that's going to be silicosis. The silicosis is the most common type of pneumoconiosis. It is a most common type of pneumoconiosis. It's the most common type of pneumoconiosis which is associated with a silica dust. It's associated with the silica dust, like a stone dust or bauxite miners Okay, if I talk about the pneumoconiotic dust, the size of the particle is 0.5 to 3 microns. 0.5 to 3 microns are most dangerous particles. They are the most dangerous particles. Is that clear to everyone? Now if we try to integrate this pneumoconiosis with a bit medicine point of view, we have a classical picture given here in the x-ray, that this calcification, what is this calcification called as? The lymph node, hilar lymph node, the calcification is called as eggshell calcification. So this is a classical picture of which calcification? Eggshell calcification. And eggshell calcification is a feature of which pneumoconiosis? Your answer is going to be silicosis. Excellent. Your answer is going to be silicosis. Okay, now I have one more question to you guys. Now tell me popcorn calcification on chest x-ray. Now if the question mentions that a patient is having a popcorn calcification, what will be your answer, bachcho? Popcorn calcification. So the popcorn calcification is seen in, comment down your answers. Popcorn calcification is seen in on chest x-ray. Excellent. Yes, that's going to be pulmonary hematoma. That's going to be pulmonary hematoma. That's going to be pulmonary hematoma, and the pulmonary hematoma is going to be the most common benign tumor. It's going to be the most common benign tumor of the lungs. It's going to be most common benign tumor of the lungs. And if I talk about this popcorn calcification, this popcorn calcification on mammography, this popcorn calcification on mammography, that's going to be the classical case of a fibroadenoma. So remember this extra information. Let's try to integrate these sessions of PSM so that you can remember. That's going to be a fibroadenoma. That's going to be the fibroadenoma. Is that clear to everyone? So popcorn calcification, then you already know the Hodgkin's lymphoma popcorn cell we have, but remember for now at least mammography, popcorn calcification, your answer is going to be fibroadenoma. And if the popcorn calcification is seen in the chest x-ray, that's going to be pulmonary hematoma. That's the most common benign tumor of the lungs. And if a patient is having eggshell calcification, that's going to be the silicosis, eggshell calcification of a bilateral hilar lymph nodes. And if a patient is having a bilateral hilar lymphadenopathy, then the answer goes to the sarcoidosis. Is that clear to everyone? So remember all these things: eggshell calcification, popcorn calcification, silicosis, okay, sarcoidosis. Clear? Now one more chest x-ray finding in a patient of silicosis we have. Can you comment down the answers? What is a chest x-ray finding in this given image? What is the chest x-ray finding in the given image? What is the chest x-ray finding in the given image? This image is going to be, yes sir, it's a ground glass appearance or the snowstorm appearance. So this is going to be snowstorm appearance. This is a snowstorm appearance. It's also seen in miliary TB as well, very right, but it's also seen in the case of a silicosis. Now let's integrate this snowstorm. As well. This snowstorm, my dear students, this snowstorm appearance on USG, on the ultrasound, this snowstorm appearance is seen in, that's going to be in USG, that's going to be, yes, high datiform mole or type 1 vesicular mole. Is that clear? On USG it's going to be type 1 vesicular mole or the high datiform mole. Clear to all of you guys? Yes, chalo, excellent. Okay, chalo, next. Next sir, the people who are diagnosed with the silicosis, one important point you have to remember: the patient who are diagnosed with the silicosis need a continuous follow-up for the tuberculosis. They need continuous follow-up for tuberculosis. Is that clear to everyone? So the most common type, of pneumoconiosis is going to be silicosis. So silicosis, we have a dust called as silica dust, okay, stone dust, cement dust, bauxite miners. So these are the patients who need to have a continued follow-up for the tuberculosis. If I talk about the chest x-ray findings, we are going to have an eggshell calcification and the snowstorm appearance or the ground glass appearance. Is that clear? Yes. Now let's move to the next pneumoconiosis. That's going to be your asbestosis. The next pneumoconiosis, that's going to be the asbestosis. So what exactly is asbestosis? It is due to the exposure. It's due to the exposure to asbestos dust. Okay. Or which industries? Shipbuilding industries. Okay, and it is the only pneumoconiosis associated with malignancy. associated with malignancy. And if I talk about the recent question, yes, shipyard industries, if I talk about the recent question that was asked in the NEET PG exams, you check the recall of a PSM, see the question was asked from the pneumoconiosis, and this was the picture given. What is your diagnosis and what is the name of these bodies? Answer me in the comment section. These are the guitar shaped bodies. What are these bodies? What are these bodies called as? The asbestos bodies are called as. Yes, very good. Asbestos bodies are called as. Asbestos bodies are called as ferruginous bodies. Very good, Rahul Pios. Crayola bodies. No, Crayola bodies are seen in asthma. 3 C's of asthma, that's going to be Crayola bodies, Krishman spirals, and Charcot Leydig cells. So these are the guitar shaped bodies called as ferruginous bodies. Okay, so remember this from the NEET PG PYQ recent exams, ferruginous bodies. And these guitar shaped bodies or ferruginous bodies is a classical feature of an asbestosis. Okay, there's a classical features of an asbestosis. Now if I talk about the most common cancer, the most common malignancy associated with the asbestosis, your answer is going to be adenocarcinoma of lung. Your answer is going to be adenocarcinoma of lung. And if I talk about more specific cancer, malignancy associated, your answer is going to be mesothelioma. Your answer is going to be mesothelioma. Is that clear to everyone? So the most common malignancy is adenocarcinoma of the lung, and the most specific is going to be mesothelioma. And what are the bodies? What are these bodies that are found in the mesothelioma? Calcium containing calcium centered bodies. What are these bodies called as? They are called as Samoma bodies. These are called as Samoma bodies, and these Samoma bodies are also seen in, what are the conditions, sir? So P, that is the papillary thyroid cancer. Sir, S, that's going to be serous cis adenoma of the ovary. Sir, M is going to be meningioma and mesothelioma. That's going to be meningioma and mesothelioma. Is that clear to everyone? So what are these bodies? They are the Samoma bodies found in papillary thyroid cancer. Along with that, you have one more feature over there, orphan ani nuclei. S goes with a serous cis adenoma of the ovary. Okay, M goes with meningioma and mesothelioma. Excellent. Yes, dystrophic calcification is seen in. Very good. Dystrophic calcification is seen. What exactly is metastatic and dystrophic calcification? I will discuss that in the pathology. Is that clear? So this is all about an asbestosis. Now let's move to the next part, that is going to be anthracosis. That's going to be anthracosis. The agent in the anthracosis, it is due to the exposure of coal dust. It is due to the exposure to coal dust. Okay, and a patient will have progressive massive fibrosis. There is a massive fibrosis, and even if the patient is removed from the exposure, the fibrosis still continues. Is that clear? And if a patient is having rheumatoid arthritis, plus anthracosis, anthracosis, that is called as which syndrome, bacho? That is called as which syndrome? Write down in the comment section. So that's called as Kaplan syndrome. Which is also called as rheumatomycosis. Rheumatomycosis. Is that clear to everyone? Rheumatomycosis. Yes, so the patient having exposure to the coal dust, okay, progressive massive fibrosis, rheumatoid arthritis plus anthracosis, Kaplan syndrome. Kaplan syndrome. Okay, one more thing I will add on here. This anthracosis, a patient will have a pigmentation inside. Okay, anthracotic pigment, that is also called as black lung due to the carbon particles. That is also called as black lung. And the most common exogenous pigment, the question from the pathology general path, the most common exogenous pigment, that's going to be your anthracotic pigment, which is also called as black lung. Yes, neutropenia, splenomegaly, that's going to be a Felty syndrome. Excellent, that's going to be a Felty syndrome. Is that clear to everyone? Is that clear to everyone? Yes. Now let's move to the next one, Bagassosis. Let's move to the next pneumoconiosis, that's going to be Bagassosis. So what exactly is Bagassosis? It is due to the exposure to which dust? It is due to the exposure to which dust? Sugarcane dust. Sugarcane dust. And for example, the examples that give is a cardboard manufacturing industry. Okay, cardboard manufacturing, sugarcane dust. Okay, if I talk about the fungus associated, you will mark answer as Thermoactinomycetes saccharine. Thermoactinomycetes. Okay, and the prevention for the Bagassosis. And the prevention for the Bagassosis is going to be 2% propionic acid. That's going to be 2% propionic acid. That's all about the Bagassosis. That's all about the Bagassosis. Yes, cardboard industries, cardboard manufacturing industries. Good. Be interactive like this. Keep answering so that it will be a revision to you guys. Okay. Now the next one is going to be the Bagassosis. And Bagassosis, sir, it is due to the exposure. It's due to the exposure to cotton dust. Exposure to cotton dust. Monday chest tightness. Okay, exposure to cotton dust. If I talk about farmer's lung or moldy hay, if I talk about farmer's lung or moldy hay, okay, the dust is going to be the dust is going to be grain husk. The dust is going to be grain husk. Okay, and the agent is Mycopolyspora fani. Yes, the agent is Mycopolyspora fani. The agent is Mycopolyspora fani. And the prevention is with the 1% mineral oil. So the prevention with 1% mineral oil. The prevention with 1% mineral oil. If I talk about other ones, Syndromic, that is due to the exposure to iron. That's due to the exposure to iron. If I talk about bird fancier lung, it's again a pneumoconiosis, that is due to the exposure to bird droppings. That is an exposure to bird droppings. If I talk about berylliosis, that is associated with airspace industries. That is associated with airspace industries. So this was all about the pneumoconiosis and their clinical features. Is that clear to everyone? Is that clear to everyone? So yes, we discussed about a silicosis, important one, asbestosis, anthracosis, Bagassosis, Bagassosis, farmer's lung, Syndromic, bird fancier lung, and the berylliosis. Is that clear to everyone? Is that clear to everyone? Yes? Good, good. Now try to answer this question. A 70-year-old retired construction worker presents with the dyspnea and the weight loss. He has a history of asbestos exposure. A chest x-ray reveals the pleural thickening and a mass in the lower lung zone. Okay, there is a pleural thickening and there is a mass in the lower lung zone, and it is due to the which exposure? Asbestos exposure. What is the most concerning diagnosis? 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 Yes, write down in the comment section, everyone. I'm checking the answers. Don't mark the silly mistakes. Most of you are marking a wrong answer. Read the question again, read the findings. Yes, read the findings, read the question again, and check what exactly it's asking. What is the most concerning diagnosis? There is a mass in the lower lung zone. There is a mass in the lower lung zone. That is going to be mesothelioma. Yes, that is going to be mesothelioma. What is the answer? Yes, asbestos exposure is asbestosis there, but the patient is giving, the clinical case is giving the x-ray findings that there is a mass. Okay, there is a mass in the lower lung zone, and that is a classical feature. What? Mesothelioma. Plural, that's why it's also called as plural mesothelioma. Mesothelioma of the pleura. Is that clear? Now my question to you guys, you most of you have revised your sessions. Tell me what is exactly a marker of mesothelioma? Anyone? Marker of mesothelioma. Marker of mesothelioma. What will be your answer for the marker of mesothelioma? Marker for mesothelioma. Anyone? Marker for mesothelioma. Started with the C. Yes. That's going to be calretin. That's going to be calretin. Is that clear? Chalo. Next question. As per the national immunization schedule. As per the national immunization schedule. Okay. Which vaccines are indicated at the first visit for immunization of a 13-month-old baby who has not been previously immunized? Now you have a patient coming to you. Okay, there is a child is 13 months old. Child is 13 months old. He has not been vaccinated. He is not vaccinated at all. Now what are the vaccines you can give at 13 months of age? What will be your answers? Write down your answer in the comment section. You have a baby coming to you, 13 months old. He has not been previously immunized. Now, out of these options, what are the vaccines you can give at the 13 months? In simple words, tell me about the delayed immunization schedule. Tell me about a delayed immunization schedule. Okay, comment down your answers. Yes. Comment down your answers. BCG can't be given after 1 year of age. Maximum is 12 months. Yes, correct, Dr. Puneet. Yes, you cannot give BCG. So option A and C is already ruled out. You can give BCG up to 12 months only. So option A and C already ruled out. Now answer is between B and D. So what exactly is the answer? Let's discuss the important chapter, all the vaccines, universal immunization schedule, about an adverse effect, about the dosage, about the diluents, and along with that delayed vaccination schedules and the strains. So let's discuss about first the immunization program. At birth we are giving how many vaccines? Vaccines are very important. Okay, so we are going to discuss everything about these vaccines. Now if we talk about birth, at birth what are the vaccines you are giving? We are giving 3 vaccines. That is going to be Bob. What is Bob? We are giving BCG, we are giving OPV, and we are giving Hep B. We are giving BCG, we are giving OPV, and we are giving Hep B. Okay, at 6 weeks we are giving diphtheria, pertussis, tetanus, DPT1. We are giving OPV1. We are giving Hep B1. We are giving HIB1. We are giving Rota 1. Is that clear? Then 10 weeks and 40 weeks followed the same by second and third dosage. DPT2, OPV2, Hep B2, HIB2, Rota vaccine 2. Then at 14 weeks we are giving DPT3, we are giving OPV3, we are giving Hep B3, we are giving HIB3, and we are giving Rota vaccine 3rd. Okay, At 9 months, so what are the vaccines? We are giving MR, we are giving Japanese encephalitis 1. Okay, we are giving again a pneumococcal vaccine booster dose. We are giving pneumococcal vaccine booster dose, and we are giving also vitamin A. Remember, for your information, vitamin A given at 9 months, okay. Followed by that, if we talk about 16 to 24 months, we are giving OPV booster 1, we are giving DPT booster, and we are giving Japanese encephalitis 2, and we are giving MR2. 5 years, we are giving DPT booster 2, okay. 10 to 16 years, we are giving tetanus, diphtheria, Tdap. Is that clear? Is that clear to everyone? So this is about a universal immunization program. But now the question that they ask, they don't ask these questions, they ask usually question about the delayed vaccination schedule. The question that they usually ask is the delayed vaccination schedule, okay. Now if we talk about a delayed vaccination schedule, first of all remember BCG. First of all remember BCG, and BCG can given up to 1 year. BCG can be given up to 1 year, okay. Next is going to be IPV, that's also given up to 1 year. IPV, that is up to 1 year. If we talk about rotavirus vaccine, again rotavaccine vaccine up to 1 year. Rota vaccine virus up to 1 year, okay. If I talk about pentavalent, first dose, if I talk about pentavalent first dose, that can be given up to 1 year, can be given up to 1 year, that can be given up to 1 year. If I talk about pentavalent second and third dose, if I talk about pentavalent second and third dose, pentavalent second and third dose can be given up to 7 years. It can be given up to 7 years, okay. If I talk about pneumococcal vaccine, that can be given up to 1 year. Pneumococcal vaccine can be given up to 1 year. OPV, MR, MMR, that can be given up to 5 years. That can be given up to 5 years, okay. And Japanese encephalitis can be given up to 15 years. So in short, my dear students, remember that BCG, IPV, RVV and PCV, these and the pentavalent first dose, these are the vaccines that can be given up to, how many years? That can be given up to 1 year. So BCG, IPV, rota vaccine and pneumococcal vaccine and the first dose of pentavalent, that can be given up to how many years? That can be given up to 1 year. With the blue one, first, second and third dose of a pentavalent vaccine can be given up to 7 years, okay. OPV, MMR, measles, mumps, rubella, can be given up to 5 years. Japanese encephalitis up to 15 years, that can be given up to 15 years. Now is that clear to everyone? Now what will be the answer for the given question? Already BCG and C and D is ruled out. C and D is ruled out because you already know that BCG can be given up to 1 year. So option A and C is ruled out. Now then option B and D. Then option B and D. From the B and D, first dose of pentavalent again can be given up to how many years, bacho? So that can be given up to 1 year. Now what will be the answer for this given question? Write down in the comment section what will be the answer for the given question. As per the national immunization schedule, what will be the answer for the given question? He has not been previously immunized. How come answer will be B? Is 13 months old. Pentavalent first dose can be given up to 1 year. All the people who are answering option number B, pentavalent first dose can be given up to how many years? It's up to 12 months. So you cannot give option B as well. BCG both ruled out. The answer is going to be OPV first dose, DPT first dose, and measles first dose. Is that clear to everyone? Is that clear to everyone? Yes? Yes, the answer is option D. Okay, and this is the question that they usually ask from the vaccines now. Okay, usually the question that they ask is about the delayed immunization schedule and the adverse effect of these vaccines All clear, bacho? Yes, guys? Yes? Chalo. Next. Now you already have studied from the microbiology and PSM as well the strains of the vaccines. Let's have a quick review. Let's have a quick revision of the vaccines and the strains. If we talk about the first vaccine, the first one we're going to talk about is BCG vaccine. Now what is the strain for the BCG vaccine? That's going to be Danish 1331. Okay, if I talk about second one, yellow fever. If I talk about second one, yellow fever, that's going to be 17D. That's going to be 17D. Okay, if I talk about Japanese encephalitis, live and kill. If I talk about Japanese encephalitis live, the answer is going to be SA 1414-2. And Japanese encephalitis kill, the answer is going to be Nakayama. The answer is going to be Nakayama. Remember the question that has been asked in the PYQs about the yellow fever validation certificate. The yellow fever vaccination is valid after the 10 days of an administration till the lifelong. Okay, after the 10 days of administration till lifelong. Is that clear to everyone? Now next, if I talk about Rota vaccine. If I talk about Rota vaccine, what is the name of the strain? R1XX414. Okay, if I talk about influenza, that's going to be A72009 Caliph. A72009 Caliph. Okay, if I talk about measles, that's going to be measles Admonstron Zagreb. Measles is going to be Admonstron Zagreb. If I talk about mumps is going to be Geraldine. Mumps strain is going to be Geraldine. If I talk about rubella, what is the name of the vaccine strain of rubella? That's going to be RA273. RA273. If we talk about chickenpox, or the another name, varicella zoster, what is the name of the vax strain? That's going to be Oka strain. And then IPV, that's going to be Salk. And OPV, that's going to be Sabin. Okay, now this is all about a vaccine and the strains. Is that clear? So BCG is Danish 1331, yellow fever is 17D. Remember, the certificate, the validation of the yellow fever vaccination is valid after the 10 days of administration till the lifelong. Japanese encephalitis live is going to be SA 1414-2. Japanese encephalitis kill is going to be Nakayama. Rota vaccine R1XX414. Influenza, that's going to be A72009 Caliph. Measles is going to be Admonstron Zagreb. Mumps, Geraldine. Rubella, RA273. Chickenpox, Oka or varicella zoster Oka. IPV is Salk and OPV is Sabin. Okay, now the diluents of the vaccine. Now tell me, what are the vaccines having normal saline? As a diluent? Remember, the vaccine having the diluent as a normal saline is going to be BCG, yellow fever and dengue. BCG, yellow fever, and dengue. Is that clear? Chalo. What are the vaccines? What are the vaccines that do not need any diluent? Vaccines that do not need any diluent. Vaccines which are available in the liquid form, no diluent needed. That's going to be DPT and Hep B. No diluent needed. That's going to be DPT and Hep B, and also tetanus toxoid. They don't need a diluent. They don't need a diluent. Okay. Now, what are the vaccines? Okay, Japanese encephalitis. Yes, Japanese encephalitis ke liye we give phosphate. We give phosphate saline buffer. We give phosphate saline buffer. Japanese encephalitis, phosphate saline buffer. What are the vaccines in which we use normal water or the distilled water as a diluent? Distilled water. That's going to be Sir MR, measles, rubella. Distilled water is going to be measles and rubella. So that's about the diluents of vaccine. That's about the diluent of vaccines. Clear? That's clear? Yes? Everyone, all clear? Any doubt so far? Chalo, let's move next. Now, the adverse effect following immunization. Now, what are the adverse effects after the immunization? So ideally you have to observe, keep the child under the observations for 30 minutes. I will write here observation 30 minutes. Now, there are some adverse effects that are associated with the rota. Yes. Now, there are adverse effects that are associated with the following vaccines. Now, let's discuss what are the adverse effects and let's discuss what are the vaccines. Okay. Now, if I talk about the paralysis, answer me in the comment section. Paralysis is a side effect of patient complaining of paralysis. It will be the side effect of which vaccine, bacho? OPV. It will be a side effect of OPV vaccine. If I talk about hypersensitivity reaction and shock, hypersensitivity reaction and shock, that is a feature of which vaccine? That is a side effect of which vaccine? Hepatitis B. That is going to be the side effect of hepatitis B. If I talk about toxic shock syndrome, what is an associated or causative agent? Toxic shock syndrome. Stafford, yes. It is due to the which vaccine? Measles vaccine. It is due to the measles. It is due to the measles vaccine. Next, if I talk about GBS, Guillain-Barre syndrome, so it's due to the killed influenza. It is due to the killed influenza. It is due to the killed influenza. Next one, if I talk about intussusception, patient complaining of what? Sausage shaped lump along with that currant jelly stool, red color currant jelly stools. Yes, intussusception. That's going to be rota vaccine. Very good. That's going to be rota vaccine. Next, any other vaccine you remember and the side effect? Febrile seizures. That's again going to be measles. That's again associated with the measles. Febrile seizures, that's going to be measles. Okay. Anyone else? Persistent crying. P for persistent crying. That's going to be pertussis. Write it down. Persistent crying. that's going to be pertussis. Persistent crying, that's going to be pertussis. One more important one, guys, thrombocytopenia. Anyone in the comment section? Thrombocytopenia. Thrombocytopenia. Thrombocytopenia is a side effect of MMR and Hep B. MMR and Hep B. So that's all about the side effects. Okay, neurological complications, again DPT. Okay, DPT, persistent crying with the pertussis. Neurological complications, again DPT. That's all about the adverse effect. That's all about the adverse effect of the vaccines. Okay, so let's revise these adverse effects. BCG, axillary lymphadenitis. Very good. Yes, BCG causes axillary lymphadenitis. BCG with axillary lymphadenitis. Okay, so paralysis with OPV, hypersensitivity reaction and the shock with hepatitis B, toxic shock syndrome, that's going to be with measles vaccine, GBS, Campylobacter jejuni, that's going to be kill influenza, intersusception, sausage shaped lump with the red currant jelly stools, target sign, rota vaccine, febrile seizures, that's going to be measles, persistent crying, pertussis, thrombocytopenia, MMR and Hep B, and BCG with the axillary lymph nodes. BCG with the axillary lymph nodes. Again, that's going to be very important question from the vaccines point of view. They usually don't ask the strains now. If you check the PYQs, they don't ask strains much. They don't ask the normal immunization schedule. What exactly they ask from the vaccines is the first adverse effects in form of a clinical case and delayed vaccination schedule. Now what will be the answer for this given question? Answer me. What will be the answer for this given question? What will be the answer for this question? A 10-year-old child develops the ascending muscle weakness 3 weeks after receiving the vaccine. Neurological examination shows areflexia. Which of the following vaccine is responsible? So muscle weakness is there. What is your diagnosis? What is your diagnosis? Bacho, what is your diagnosis? What is your diagnosis? Very good. Guillain-Barr syndrome, GBS is a diagnosis, and GBS, you know, associated with Campylobacter jejuni as well, and it's an adverse effect of the which vaccine? It's going to be the adverse effect of the which vaccine? Yes, it is going to be the adverse effect of the which vaccines, and it's going to be the adverse effect of the killed influenza. It's going to be the adverse effect of the killed influenza. Is that clear? Guillain-Barr syndrome. Is that clear to everyone? Chalo, next. Let's move to the next question. Before that, let's discuss the mission Indradhanush. Okay, now what exactly is this mission Indradhanush? They can ask the question, out of which of the following vaccine is not in the mission Indradhanush? Okay, out of which of the following vaccines? So we have some vaccines which come under this mission, that is the mission Indradhanush. This mission Indradhanush, it was launched 25th of December 2014. Okay, it was launched 25th of December 2014, and the aim of this mission was to give 100% coverage to the infants and the pregnant women, to give the 100% coverage to the infants and the pregnant women. Okay, first we had 7 vaccines. What are the 7 vaccines? Pehle 7 vaccines thi. What are those 7 vaccines? Okay, BCG, okay, diphtheria, BCG, diphtheria, pertussis, tetanus, OPV, Hep B, and measles. OPV, Hep B, and measles. So these were the 7 vaccines added before. Then they added 4 more. Then 4 vaccines more. What are those 4 vaccines? That is going to be pneumococcal vaccine. That is going to be not pneumococcal. The first one is going to be Japanese encephalitis. Second one is going to be IPV, inactivated polio vaccine. Then we have a rota vaccine, and we are going to have MR. These are the 4 vaccines added, and later on 2 vaccines more were added. That's going to be your PCV, and that's going to be your influenza B. So what are total vaccines? We have 13 vaccines in total. First there were only 7 vaccines, then we had 4 vaccines more, and then we have 2 vaccines more. Is that clear? And what are the beneficiaries of this? It's given to 0 to 2 years children's, and along with that pregnant female as well. Is that clear? So this is a mission Indradhanush. Okay, mission Indradhanush. Okay, now any one of you, can you tell me Abhiyan Indradhanush? For which? Abhiyan Indradhanush. What exactly was the mission about? Abhiyan Indradhanush. You guys can answer. Abhiyan Indradhanush. Anyone in the comment section? Abhiyan Indradhanush. Yes. Yes, excellent. Good. Most of you are right in the comment section. Good. Now let's move to the next question. A patient from different age groups from a village in the West Bengal came to the clinic with illness. On examination, it is noted that all of them were having edema. So what is it? Yes, bedsheet color change of ESIC workers every week. Yes. Now, on examination, it is noted that all of them were having edema. So patient coming to you, complaint is what? They are having edema. On history taking, it was found that they are consuming mustard seeds bought from the same local shop. What is your most probable diagnosis? What will be your answer, bacho? Most probable diagnosis. Somebody is writing D. How come mustard with D? Aflatoxicosis. D kahan se aayega? That is with the aflatoxin, groundnut. Your answer is going to be? Very good. The answer is going to be epidemic dropsy. Can you tell me what is a toxin associated with an epidemic dropsy? Very good. What is the toxin associated? That's going to be sanguinarine. Is that clear? Now let's discuss about the food adulteration disease. Again, I will tell you, before they used to ask directly the toxin of this food adulteration disease, but now they give a clinical picture of this patient. What exactly are the features? Of what? Endemic ascites. What exactly are the features of latherism? What exactly are the features of epidemic dropsy? And what exactly are the features of aflatoxicosis? So let's understand what exactly are the food stuff associated and the toxins, along with that the clinical features of these conditions. Now if I talk about the first food adulteration disease, that's going to be latherism. And the toxin associated with this latherism, that's going to be boa toxin, beta oxalate aminoalanine. Okay, sometimes they will not give you a short form BOAA, rather than they will write the full form. Remember, beta oxalate aminoalanine, beta oxalate aminoalanine. alanine, beta oxalylaminoalanine. The agent is going to be kesari dal. The agent is going to be the kesari dal, and the food stuff is yellow pulse. And the food stuff is yellow pulse. The food stuff is yellow pulse. Okay, if I talk about the second one, that is going to be epidemic dropsy. The toxin is sanguinurine. What is the toxin, bacho? The toxin is sanguinurine. Okay, what exactly is this toxin doing? It is inhibiting the oxidation of the pyruvic acid. This toxin is inhibiting the oxidation of a pyruvic acid. If I talk about the food stuff, that is going to be argemone seeds. That's going to be argemone seeds. Okay, and the food stuff is mustard. And the food stuff is going to be mustard. What is the food stuff associated? Mustard. Okay, next one is going to be endemic ascites. The toxin that is associated is pyrrolizidine. The toxin that is associated is going to be pyrrolizidine. Okay, and this pyrrolizidine is again an hepatotoxic. Okay, that's why the patient will complain of the features of liver involved. So what will happen? Patient will have an jaundice. Okay, so if a patient is coming to you with a jaundice and ascites, your classical features are going within endemic ascites. If I talk about an agent, that is a Coratorella seeds. Okay, and the food stuff is millet. The food stuff is millet. Crotalaria seeds, and the food stuff is millet. Okay, the next one that has been asked multiple times, that's going to be your aflatoxicosis, having a toxin aflatoxin. Kaun sa toxin? Aflatoxin. But one good thing you will remember here, it causes hepatocellular carcinoma. It is associated with a hepatocellular carcinoma. Is that clear? And then if I talk about an agent, that is an Aspergillus flavus. And the food stuff is going to be groundnut. The food stuff that is associated with this is going to be the groundnut. Okay, then the ergotism, the toxin is going to be ergot alkaloid. The toxin is going to be ergot alkaloid. Okay, and the agent is Claviceps fusiform. Agent is Claviceps fusiform, and the food stuff are the flowering plants. Food stuff is a flowering plants. So this is about a food adulteration disease. Their toxins, agents, food stuff, and the disease. Now examiner will mention either the food stuff, he will mention either the toxin, or either he will give the clinical features. Now these are the clinical features that you have to remember for these food adulteration diseases. Is that clear? Now if I talk about the first food adulteration disease, that's going to be latherism. Now you already know, so the latherism, what was the toxin? Beta oxalylaminoalanine, BOA. Okay, the classical features of a patient having a latherism. What are the classical features of the patient having the latherism? Your first answer is going to be neuroparalysis. So patient will complain of a neuroparalysis and osteoparalysis. Patient will have neuroparalysis and osteoparalysis. And the given picture in the image, given picture in the notes, this is a classical picture of what? Osteoparalysis. And it is due to the which toxin? BOA. It is due to the which toxin? BOA, or a patient taking the kesari dal. Patient having a kesari dal or the yellow pulse. Is that okay? Osteoparalysis. And osteoparalysis is going to be associated with which food adulteration disease? Latherism. Is that clear? Now the next one that's going to be epidemic dropsy. Now the next one that I'm going to talk about is epidemic dropsy. What are the clinical features of a patient having epidemic dropsy? First thing mentioned in the question only, patient will complaining of what? Bilateral swelling of the legs or the edema. Patient will have bilateral swelling of legs. So patient having edema, along with that patient will have diarrhea, patient will have dyspnea, and patient will complain of cardiac failure. Patient will complain of cardiac failure. Then this is the PYQ that has been asked in the recent exams. पिछले exams में क्या पूछा था? Patient having edema, cardiac failure, the classical diagnosis of an epidemic dropsy, the toxin associated is going to be sanguinarine. Is that clear? Is that clear? Endemic ascites, I've already told you, this is a hepatotoxic. Ascites itself is saying the patient will complaining of what? Yes, cardiac, and the patient will complaining of endemic ascites में क्या होगा? Patient को jaundice होगा, patient will have features, patient will have jaundice and ascites. Patient will have jaundice and ascites, and jaundice and ascites, they are again associated with the endemic ascites. And endemic ascites में what is the toxin? Pyrrolizidine. What is the toxin बच्चों? Pyrrolizidine. Ergotism, having a toxin of ergot alkaloid, patient will have vasospasm gangrene. And foodstuff is flowering plants. What is the foodstuff? Flowering plants. Is that clear to everyone? Is that clear to everyone? What are the clinical features? Yes. Now, an aflatoxicosis I've already discussed, groundnut, and a patient will have hepatocellular carcinoma. Multiple times, repeatedly asked question that has been asked multiple times. Clear? Now, how to control, how to prevent this? First of all, we can go removal of toxins. Removal of toxins by steeping method. Removal of toxin by steeping method or the parboiling method, or parboiling method. Okay, then we can start a vitamin C prophylaxis. We can start vitamin C prophylaxis. Along with that, we can ban the crop. We can ban the crop. Along with that, we can ban the crop, or we can aware or educate people about the disease. We can aware or educate people about the disease. We can aware or educate people about the disease. That's going to be about the food adulteration diseases. That is about the food adulteration disease, clinical features, toxins, and a food stuff. So answer here, edema, mustard. Answer is epidemic dropsy. Now answer me this question, guys. Easy one. Answer me the easy one. A 50-year-old male presents to the emergency with some form of poisoning. He has a history of working in a place where groundnuts are stored. Groundnuts are stored. What is your most likely diagnosis? What will be the most likely diagnosis? What will be the most likely diagnosis? So the answer is going to be aflatoxicosis. The answer is going to be aflatoxicosis. Groundnuts with aflatoxicosis. Is that clear? All clear to everyone? Yes. Write down in the comment section. Very good. Yes. All the topics that I'm discussing, they are the main topics that they usually ask every time. Okay, now let's have a quick recap. Recap of the food adulteration diseases. First of all, we discussed latherism. The toxin is boa, agent is kesari dal, food stuff is yellow pulse. Second one is going to be epidemic dropsy. The toxin is going to be sanguinarine, agent argemone seeds, and the food stuff is mustard. Endemic ascites is going to be pyrrolizidine. The agent is coratorella seeds, and the food stuff is millet. Aflatoxicosis, the toxin is aflatoxin. The agent is Aspergillus flavus, and the food stuff is groundnut. If I talk about ergotism, the toxin is ergot alkaloid, agent is Claviceps fusiform, and the food stuff is flowering plants. If we talk about the clinical features, latherism, patient will have a neuroparalysis and the osteoparalysis given. Okay, bilateral swelling of the legs along with the diarrhea and the cardiac failure will be associated with an epidemic dropsy. Patient having a features of jaundice and ascites is going to be endemic ascites. Patient having vasospasm, gangrene like features is going to be ergotism. How do you remove these things? Remove the toxins by steeping method or the parboiling method. Vitamin C prophylaxis, ban the crop, and aware or educate people about the disease. Is that clear? Chalo, next one. Which kit you would recommend for the treatment of a 20-year-old female? Which kit you will recommend for a female 20-year-old who recently engaged in the sexual intercourse and she's experiencing a vaginal discharge? Patient coming to you with the complaints of a vaginal discharge when following the syndromic management approach for the STDs or the sexually transmitted infections at Suraksha Clinic. Which kit you will prescribe? Which kit you will prescribe as per the Suraksha Clinic to a lady who is complaining of a vaginal discharge? What will be your answer, bacho? What will be your answer, guys? What will be your answer? The answer is going to be, where is most of you are right, everyone is right. Yes, the answer is going to be kit 2. That is which color? That is going to be green color. The kit 2, that is going to be green color. Now let's understand what exactly is this Suraksha Clinic and what are the services they provide. What are the services they provide? Now if I talk about this Suraksha Clinic, it provides sexual and reproductive health services. What are the services it provides, bacho? Sexual and reproductive health services. Okay, and this is going to be the logo for Suraksha Clinic. So this Suraksha Clinic treatment is based upon given based upon symptoms. Treatment is given based upon symptoms, not on diagnosis. Not on diagnosis. That means this is a syndromic approach. This is called as syndromic approach. Now sir, what exactly is this syndromic approach? Let me make you explain. Now for example, you have a patient complaining of a vaginal discharge. Now you have a patient coming to you with the complaints of vaginal discharge. Now this vaginal discharge can be anything. It can be curdy, it can be creamy, it can be greenish, it can be white. Okay, so it can be either trichomoniasis, so it can be either candidiasis, so it can be bacterial vaginosis, it can be any kind of discharge. But as per the Suraksha Clinic, we are giving a treatment based upon the symptoms only. So any patient coming to you with a vaginal discharge, irrespective of what is that in candidiasis, bacterial vaginosis, trichomoniasis, we have to give the kit, and each kit will in each kit there will be a medication inside that it will cure the condition. So these are the syndromic color coded kits. What are these color coded kits? Syndromic color coded kits, and inside each kit there is what? Medication. Now we'll understand what are the kits and what are the medications inside and what are the symptoms you will prescribe each kit. Now the first one, that is going to be kit 1. Now if I talk about first kit, that is kit 1, and kit 1 is which color, bacho? Kit 1 is sir gray color. Kit 1 is going to be gray color. Okay, now write down in your answers kit 1 gray color. A patient complaining of which discharge? Any patient complaining of urethral or anorectal discharge. Any patient coming to you with the complaints of urethral or anorectal discharge. What is your answer? What will be the answer? Urethral discharge or the anorectal discharge? Your answer is going to be kit 1, that's going to be gray color. Your answer is going to be kit 1 gray color. Urethritis. Okay, yes. Cervical as well. Anorectal में यहाँ पे cervical भी लिख दो. Cervical as well. If I talk about kit 2, that is going to be green color. That's going to be green color. Any patient coming to you with the complaints of, coming to you with the complaints of a vaginal discharge. किसी भी patient को vaginal discharge, you will prescribe kit 2, that is green color. You will prescribe kit number 2, that's going to be green color. Followed by that we have kit 3. we have kit 3, okay, that's going to be white. Then we have kit 4, that's going to be blue. Then we have kit 5, that's going to be red. So WBR, white, blue, red, WBR 3, 4, 5. What else do you remember with the sequence of white, blue, red? Anyone? What else you remember with the features of white, blue, red? Fingers, color change, white, blue, red. Answer me. Integrated question to you guys. Color sequence, white, blue, red. Change of color sequence, white, blue, red. Which phenomenon? बता दो. Which phenomena? Raynaud's phenomena. Very good. Which phenomena? Raynaud's phenomena. What is the drug of choice? What is the treatment given? Again a PYQ of FMGE. Again your PYQ. What is the treatment you will give, bacho? Calcium channel blockers. What is the treatment given? Calcium channel blockers. Again, this is the question asked, that Raynaud's phenomena, what exactly is a treatment? Calcium channel blockers. What is the sequence of the color change? White, blue, red. What is the sequence of the color change? White, blue, red. Is that clear? Yes. So meanwhile we are trying to integrate this PSM as well, so that it will be interactive. Okay, na? Most of people think PSM is dry, but we'll make it interactive as much as we can. So keep answering. Now let's come back to this Suraksha Clinic. Kit number 3, that is going to be genital ulcers. Genital ulcers, but these genital ulcers are non-herpetic. They are non-herpetic, okay, and they are responding to penicillin. I'm just writing penicillin here, so that means they are responding to penicillin. Okay, blue color, again they will be genital ulcers. They will be genital ulcers. Again it will be non-herpetic. It will be non-herpetic, but they will be allergic to penicillin. I'm writing cross to penicillin. They will be allergic to penicillin. Red color will be genital ulcers, herpetic. There will be genital ulcers that will be herpetic. Herpetic genital ulcers, herpes. Is that clear? Is that clear? So sir, we have genital ulcers, we have non-herpetic responding to penicillin, we have blue genital ulcers, non-herpetic, they are allergic to penicillin or they're resistant to the penicillin, or kit 5 red genital ulcers, herpetic. Is that clear? Then we have kit 6. We have kit 6, that is going to be yellow color. And in case of yellow color, any patient coming to you with a complaint of lower abdominal pain, patient complains of lower abdominal pain, usually PID, what is the kit you will prescribe? So we are going to prescribe the yellow color kit. We are going to prescribe the yellow color kit. Okay, and the last one, patient complaining of what? Patient complaining of the inflamed lymph nodes. We are giving a kit, black color, that's going to be inguinal bubo, or the inflamed lymph nodes. Inflamed lymph nodes. So this is all about the Suraksha Clinic and the genital Suraksha Clinic symptoms and the kit prescribed. Is that clear to everyone? Yes. So kit 1, gray color, urethral, anorectal or cervical discharge. Sir, kit 2, that's going to be green or vaginal discharge. Kit 3, that is going to be genital ulcers, non-herpetic, penicillin, responding to penicillin. Kit 4, that is going to be blue color, genital ulcers, non-herpetic, resistant to penicillin. Kit 5, that is going to be red color, genital ulcers, herpetic. Kit 6, lower abdominal pain. And kit 7, black color, that's going to be inguinal bubo. That's going to be inguinal bubo. Is that clear? Is that clear to everyone? Write down in the comment section. All clear? Yes. So they will give the symptoms, followed by that you have to prescribe the kit. They will sometimes write kit 4 is green, kit 2 is green, kit 1 is green, kit 7 is green. Okay, so you have to answer accordingly. You have to answer the accordingly. Okay, so kit 1, remember 1 gray, 2 green, 3 white, 4 blue, 5 red, 6 yellow, 7 is black. Sir, medications. Okay, remember the medications as well. They can ask the medications, but yes, I think your level they will not ask. But again, if you want to remember what are the medications in each kit, write it down here. Gray color mein we have two drugs, azithromycin. Gray color we have two drugs, azithromycin plus cefixime. Azithromycin belonging to class of what? Macrolides, cefixime, cephalosporins. Okay, green color we have fluconazole and secnidazole. Fluconazole and secnidazole. White color we have azithromycin. So white color we have azithromycin plus, I have already mentioned the white color we have genital ulcers, non-herpetic, they are responding to the penicillin. So along with that we have penicillin as well. Kit 4, that is going to be blue color. We have kit 4 is blue, that is resistant to the penicillin, so there will be no penicillin. There will be azithromycin and doxycycline. Azithromycin and doxycycline. Is that clear? Azithromycin and doxycycline. So what are left one? Red color. So red color you already know herpetic conditions. क्या दोगे drug बच्चों? Sir will give acyclovir. What is the drug that will be inside the red color? That's going to be acyclovir. Red color में acyclovir. Next one is going to be the yellow color, having association of a PID, lower abdominal pain. We are giving 3 drugs in yellow color, 3 antibiotics. Yellow में क्या क्या देंगे? First of all we are giving cefixime, we are giving metronidazole, and we are giving doxycycline. Last one is going to be black color, and black color में क्या देंगे? We are giving 2 drugs again in the black color as well. What are the 2 drugs? Azithromycin and doxycycline. What are the 2 drugs? Azithromycin plus doxycycline. Is that clear? हो गया drugs भी clear? Okay, so red, yellow, black is here, gray, green, white and blue is here. Again, a NEET PG recall question was asked that a patient was having urethritis. What is the combination of the drug inside the kit? Urethritis mein what will be the combination of the drugs? Write down in the comment section. In urethritis, what will be the combination of the drugs? So the combination of drugs is going to be, yes, azithromycin and cefixime. Urethritis will going with the kit gray. Next question. Which type of cancer won't be affected if a patient uses OCPs, which is a protective factor for? That simply means that OCPs are decreasing which cancer? OCPs are decreasing which cancer? What will be your answer? OCPs are decreasing which cancers? Very good. Yes, everyone try to answer. You have studied. All those students who have regular classes, you guys have studied. Yes. So OCPs are protective for, or they decrease the chances of which cancer? Very right, endometrial cancer. So the answer is going to be endometrial cancer. Right now the main important part is, bachcho, what is the main important part? We have to understand the full topic. Questions will not be repeated, but topics वहीं से आएंगे. Topics will be same. That's why high probability topics we are discussing. Okay. हाँ जी, part 2 I will also take. Okay, PSM is a big subject. We'll try to do in 2 parts. So maximum revision. Remember, at least you should not skip these topics. Okay, go check out the PYQs of NEET PG, check out the PYQs of FMG. These are the same topics. यहीं से पूछते हैं. Okay, so don't try to make silly mistakes. Yes, chalo. Now if we talk about combined OCPs, क्या होता है उनमें? Estrogen, we have estrogen plus progesterone. We have estrogen plus progesterone, like Mala N and Mala D. What are the examples? Mala N and Mala D. Okay, Mala N and Mala D. Okay, what is an estrogen inside? Sir, we have ethinyl estradiol. So we have ethinyl estradiol. How much ethinyl estradiol? We have 30 micrograms. And we have a progesterone in the form of a levonorgestrel, 150 micrograms. Levonorgestrel is a progesterone. Which generation? Second generation. Levonorgestrel, how much? 150 micrograms. We have 150 micrograms. Okay, now OCPs increase some cancers, OCPs increase some cancers, and OCPs decrease some cancers. What are the cancers that OCP increase? The most common cancer associated with the OCPs. Anyone in the comment section? What is the most common cancer associated with the OCPs? Or OCPs increase the chances of which cancer? What will be your answer? Again on PYQ. OCPs increase which cancer? Or the most common cancer associated with the OCPs is going to be? Not breast. Okay, right. OCP increase the cancers. First, right, hepatic adenoma. Right, hepatic adenoma, even hepatic hemangioma as well, but you remember first one, hepatic adenoma. Okay, hepatic adenoma. Next one is going to be cervical cancer. Next one is going to be cervical cancer. They increase the chances of cervical cancer. And then breast cancer, and then breast cancer. So hepatic adenoma, hepatic cancers, cervical cancers, breast cancers. Is that clear? And the cervical cancers usually with which HPV? 16 and 18. If you have to choose one, choose 16. Okay, now OCPs decrease the which cancer? First one is going to be, sir, endometrial cancer. Endometrial cancer. But there is a drug that increases the chances of endometrial cancer by causing a hyperplasia of the endometrium, increased number of cells in the endometrium. What is the drug and what is the class of the drug? Again, multiple times it has been asked in your exams. A drug having an hyperestrogenic state. What is the name of the drug? And usually they ask the class as well. So the drug name, क्या है drug का नाम? That is used in the breast cancer. The drug is used in a breast cancer. So the answer is going to be very good. The answer is going to be tamoxifen. Excellent. The answer is going to be tamoxifen. Very good. All the students who are regularly commenting, very nice. Okay, the answer is going to be tamoxifen. Answer, the drug belongs to the class SERM, selective estrogen receptor modulator. Now in order to decrease the side effects, we are using a drug called as raloxifene. Instead of tamoxifen, use what? Raloxifene. Instead of tamoxifen, use raloxifene, so that patient will not have what? Okay, so this tamoxifen causes endometrial, it causes an endometrial hyperplasia. It causes endometrial hyperplasia, which will further cause endometrial cancer, Okay, and the classical feature in OB/GYN we have studied, the classical presentation of a patient having an endometrial cancer is going to be a post-coital bleeding or even the post-menopausal bleeding. Okay, post-coital is usually associated with what? Cervical cancer. But when a patient along with the post-menopausal bleeding or the post-coital bleeding, patient क्या complain होगा? Patient obese होगा, patient is obese, patient is diabetic, patient is hypertensive. What is your answer? These three things: obese, hypertensive, diabetic. What is your answer? Endometrial cancer. What is your answer? Endometrial cancer. But post-coital bleeding, pyometra, है ना, post-coital bleeding, pyometra, HPV 16 and 18, that's going to be the cervical cancer. That's going to be the cervical cancer. Okay, chalo, okay. And the drug that we have to use, the drug that we use is raloxifene, because tamoxifen don't use. क्या करोगे use? And this raloxifene is also used in an osteoporosis है ना, but drug of choice for osteoporosis is, that's going to be bisphosphonates, but females before the menopause, estrogen. Chalo, now decreased, it also decreases which cancer, sir? Ovarian cancer. So it also decreases ovarian cancer. And the next one, it also decreases the uterine cancer. It also decreases the uterine cancer. So what? Yes, bisphosphonates. Yes. Chalo. So what are the cancers increase? Sir, hepatic adenoma, cervical cancer, breast cancer. So what are the cancers decrease? Endometrial cancer, ovarian cancer, and the uterine cancer. Now let's talk about the contraindications. Of these OCPs. First of all, absolute contraindication. You don't have to give at all. Dena hi nahi hai. What are the absolute contraindication? Cardiovascular disease. Patient having a liver disease. A patient ko liver disease already hai. So if you will give the OCPs, what will happen? Hepatic adenoma. ठीक है ना? Patient having a uterine bleeding. Okay, next, in case of pregnancy or thromboembolism. Is that clear? Chalo, next, relative contraindications. So relative contraindication, usually age less than 40. Okay, renal disease. Patient having renal disease. Patient having diabetes. Patient having migraine. Patient ko migraine hai. Patient having hypertension. Then it is going to be contraindicated. It is a contraindicated. Is that clear to everyone? So what are the drugs? What are the cancers that will increase? Remember HCB, hepatic adenoma, cervical cancer, breast cancer, decrease endometrial cancer, ovarian cancer, and uterine cancer. Okay, then the tamoxifen as well. Okay, tamoxifen, yes, Wilson में liver involved होता है, तो that is also a contraindication because it causes hepatic adenoma. ठीक है, tamoxifen. Then tamoxifen is a drug that will increase the chances of what? Endometrial cancer. Rather than that, use raloxifene. It belongs to which drug class? SERM, selective estrogen receptor modulator. Is that clear? Chalo. Next question. What is an absolute contraindication for the device depicted in the image below? What is the name of the device? Bata do. Yes. What is the name of the device? Answer in the comment section, bachcho. What is an absolute contraindication? So that is going to be copper T. Okay, so this is an intrauterine contraceptive device. Which generation, bacho? Sir, it is going to be a second generation. So what are the second generation IUCDs? They are containing copper. And it is copper T380A. Okay, and what is the lifespan of the copper T380A? What is the lifespan of a copper T380A, bacho? So that is 10 years. That is going to be 10 years. Now if I talk about this, the different generations of IUCDs, remember, first generation we have Lippes loop. Do you remember? First generation we have Lippes loop. Second generation we have copper containing copper T380A. Third generation we have levonorgestrel containing LNG containing what? Yes, that is going to be Mirena, having a lifespan of 5 years. Fourth one is going to be Flexigard. first one is going to be Flexiguard. These are the different generations of IUCDs. I will discuss later on as well. So Lippes loop, previous exams your IUCD was asked Lippes loop. Okay, Lippes loop पूछा था, ठीक है? Is that clear? And yesterday I mentioned that Mirena LNG is a treatment for which condition? Mirena LNG is a treatment of which condition we have studied in the OB/GYN high topics. Mirena is a treatment for which condition? किस condition में you can give it as a treatment? Endometriosis, along with the depot medroxyprogesterone acetate, because progesterone is used as a treatment in endometriosis. Chalo. Now, if what will be the what will be the absolute contraindication? The answer is going to be, sir, vaginal bleeding. Vaginal bleeding. Is that clear? Answer is going to be the vaginal bleeding. Is that clear? Adenomyosis में the mainstay of the treatment is directly going to be the hysterectomy, because patient is 45 plus. Endometriosis में mainly begin Mirena. Okay. Chalo. Now IUCDs and the contraindications. I've already told you about different types of IUCDs. Now, so we have a contraindication. Either the contraindication is what? Absolute. Either the contraindication is relative. Okay, relative contraindication and absolute contraindication. Relative contraindication and absolute contraindication. The first one, what are the absolute contraindications? If there is suspected pregnancy. If you are suspecting the pregnancy, it's an absolute contraindication. Okay. Then next one is going to be current PID. Next one is going to be current PID. Next one is going to be current PID. Okay. Then the third one is going to be undiagnosed bleeding PV. The third one is going to be undiagnosed bleeding PV, or you can write abnormal uterine bleeding. Okay. Yes, that's what I'm saying. Undiagnosed bleeding PV or an abnormal uterine bleeding. Any bleeding from the genital tract other than the normal menses is an abnormal uterine bleeding. Is that clear? Any bleeding other than the normal menses is going to be what? Abnormal uterine bleeding. Is that clear? Yes, Puneet. So that's why I mentioned undiagnosed bleeding PV. That's going to be a absolute contraindication. Okay. So among the four options given, all other are what? Relative contraindications. Either if there is a malformation of the uterus, like a bicornuate uterus, okay, septate uterus. So simply that is going to be a relative contraindication. Now the side effect of a IUCD, if I will tell you, the side effect of the IUCD, if I'll tell you, is what? Menorrhagia. It causes heavy bleeding more than 80 ml. Okay, it causes bleeding more than 80 ml. Okay, when it causes bleeding more than 80 ml, patient is already anemic, so or blood loss ho jayega. So patient will have what? More anemia, relative contraindication. Okay, or the patient having a multiple sex partners, patient will have infection, and most common reason taking out an IUCD is what? Infection. That's why it's a relative contraindication. So all other things, whether fibroid, what will happen with the fibroid is a relative contraindication. Fibroid will go bigger. That can cause a perforation of an IUCD inside. Okay, displacement of an IUCD when the fibroids will grow. Okay, so all other are what? Relative contraindication. So if you choose among the given options 4, you have to choose what? Vaginal bleeding, undiagnosed vaginal bleeding. Is that clear? Okay, abnormal menses hoga to I would have clearly given an option. So here the answer is vaginal bleeding. Undiagnosed bleeding per vaginal is going to be a absolute contraindication. Is that clear? Is that clear now? Yes, guys, everyone, it's clear? Not a complicated thing. Normal है, undiagnosed bleeding PV होगी तो absolute contraindication है. Update me in the comment section so I can go ahead. Make sure that you get all your concepts clear, whatever I'm discussing. You are allowed to ask anything. Yes? Yes, sir. Clearly clear, okay? All clear, guys? What was the name of the guy? Dr. Puneet. It's clear now? Chalo. Good. Okay, now one more. If a patient is having a history of ectopic pregnancy, if a patient is having a history of ectopic pregnancy, PDF भी दे दूंगा, I will give PDF as well. If a patient is having a history of an ectopic pregnancy, again that is going to be the absolute contraindication. So what are the relative contraindications? Like patient is anemic, because the most common side effect of IUCD is going to be menorrhagia, and this exam question was asked, patient is having menorrhagia, okay, followed by IUCD, what is your management? Write down in the comment section. Patient complaining of a menorrhagia, patient had IUCD inside, what will be your management? What will be your management? Patient is having menorrhagia, IUCD inside, patient is having IUCD, menorrhagia, what will be your management? What will be your management? Write down the answer. What will be your management? क्या करोगे? What will be the management of a patient having a menorrhagia followed by IUCD? IUCD लगाने के बाद no, don't mark remove IUCD. Reassurance plus folic acid. You will give reassurance plus folic acid. But if the patient is having pain, and pain is due to the infection, at that time your answer should be remove the IUCD and start antibiotics. Okay, मैं लिख लेता हूँ यहाँ पे. This is the mistake that you guys make. Okay, patient is having IUCD inside. Okay, followed by that patient having heavy bleeding. Sir, heavy bleeding हो रही है, क्या करूँगा? Reassurance. This is your PYQ, reassurance plus folic acid. ठीक है, this is your PYQ. Okay, don't PYQs तो गलत करने ही नहीं है. Okay, if patient is having sir pain, अगर पेन है तो क्या करोगे? Remove IUCD and start antibiotics. Sir, patient having the failure of IUCD. What is failure of IUCD? Patient is pregnant with the IUCD inside. What you will do again? Sir, remove the IUCD. Need PG recall. Remove the IUCD. Okay. So patient with IUCD, heavy bleeding, reassurance plus folic acid. Pain हो रहा है, take it out, start antibiotics. Failure हुआ, pregnancy with IUCD in situ, remove the IUCD. Then the further steps you will do. Sir, if you are not able to find IUCD, अगर मिली ही नहीं तो ढूंढो. Go for the investigations. Try to find. Go for the investigations. Okay. If you are able to see it inside the uterus, अगर यूट्रस के अंदर मिलती है तो you go with the hysteroscopy. और अगर यूट्रस के बाहर मिलती है, if you are able to find it outside the uterus, you go with the laparoscopy. So hysteroscopy inside the uterus, laparoscopy outside the uterus. Is that clear? And IUCD's questions multiple times they have been asking. So remember again, if thread visible, remove. Yes. If not, go for the investigations. If you see that IUCD is inside the uterus, hysteroscopy, outside the uterus, laparoscopy. Patient after the IUCD, heavy bleeding, give assurance plus folic acid. Patient complaining of a pain that is due to the infection, remove the IUCD, start antibiotics. Failure, remove the IUCD. Is that clear? So relative contraindication is anemia. Chalo. Fibroid. Okay. Patient having history of PID. Okay. If a current PID, then that's going to be a absolute contraindication. But if history of PID, that is going to be a relative contraindication. What are the organisms causing PID? Chlamydia and Neisseria. Chalo, PID. Then patient having malformation of the uterus. If there is malformation of the uterus, okay, septate, bicornuate, okay, or patient having a history of multiple partners, that is a relative and absolute contraindication. Is that clear? Yes. Is that clear to everyone? Please write down in the comment section. Did you understand when to go for hysteroscopy, when to go for laparoscopy? It is clear that what are the side effects, when to remove and when to give reassurance? Write down in the comment section, guys. If it's clear, so I can go ahead. We can move to the next concept. It is all clear? Yes, sir. Okay. Physical quality of life index, that is PQLI, includes all of the following parameters except. That includes all of the following parameters except. What will be your answer now? What will be your answer? Because multiple partners will cause infection. निकालना ही पड़ेगा ना. All the sexually transmitted diseases that are due to the multiple sex partners as a risk factor. Now, if a patient is having a sexually transmitted disease, pain, infection, you need to take out. That is a relative contraindication. Is that clear? Chalo. Except, very good. All, I've already said that if a patient is having a multiple sex partners, patient is more prone to the sexually transmitted diseases, infections, and when a patient is having infections, that is the main cause that you have to remove the IUCD. है ना? So that's why it's a relative contraindication. Is that clear? Yes. Chalo. Now, physical quality of life index, following parameters except. Your answer is going to be life expectancy at birth. Now, if we talk about the indicators of quality of life, we have indicators of quality life. So what are the indicators of quality life? We have two indicators. First one is going to be PQLI. First one is going to be PQLI, that is a physical quality of life index. Second one is going to be HDI, human developmental index. Physical quality of life index and human developmental index. Now, physical quality of life index, it has components. Number first one is going to be life expectancy at 1 year of age. First one is going to be life expectancy at 1 year of age. That is in the gynecology. I will explain that. Part 3 is coming for the gynecology. कोई बात नहीं. Life expectancy at 1 year of age. Okay. Second one is going to be a literacy rate. Second one is going to be the literacy rate. Okay. Third one is going to be infant mortality rate. Third one is going to be infant mortality rate. So what are the components of PQLI? Life expectancy at 1 year of age, literacy rate, infant mortality rate. Third one is going to be infant mortality rate. Okay. If we talk about the range, of PQLI, that is going to be 0 to 100. That is going to be 0 to 100. Okay. And this PQLI is your NEET PG recall. Okay. They have asked morning shift PQLI, evening shift they ask HDI. They ask the components. Sir, did they ask directly question like this? No. They asked out of which of the following components are seen in a PQLI. Then options were like A, B and C, B, C and D, B, C and A, D and B. Okay. So 3 components you have to choose. First 4 options will be given, then below that the options will be given A, B, D, B, C, D, B, C, A. So 3 components you have to remember. At 1 year of age, life expectancy at 1 year of age, literacy rate and infant mortality rate. Is that clear? And if I talk about human developmental index, write down first one. It is life expectancy. It's life expectancy at 1 year of age. It's life expectancy at 1 year of age. Second one, it's going to be knowledge. Second one, it's going to be knowledge. Okay, and the third one is going to be income, and third one is going to be income. So life expectancy at 1 year of age, knowledge, and income, these three are the components of an human developmental index. What is the range? Write down in the comment section what is the range for HDI. So that is 0 to 10. What is the range? That is 0 to 1, not 10, that is 0 to 1. Range is 0 to 1. The range is 0 to 1. So these are the components of human developmental index. Now the different names for literacy rate. We have a different names of the literacy rate. What are the names? So sometimes rather mentioning the literacy rate, they will mention, rather mentioning the literacy rate, they will mention either knowledge, they will mention either mean year of schooling, they will mention mean year of schooling, or they will mention education index. They will mention education index. So knowledge, mean year of schooling, or education index. So this is all about the different names of a literacy rate. So remember, life expectancy at 1 year of age, literacy rate, and infant, that's going to be PQLI, and life expectancy at 1 year of age, knowledge and income, that's going to be HDI. 0 to 100 range with PQLI, 0 to 100 with the HDI. Let's move to the next question, guys. Chalo, is that clear? Write down in the comment section. All clear? Yes, write down in the comment section, guys. It's clear? All of you guys? Yes. Chalo. All clear? So answer is going to be D. Chalo. Next, a ASHA worker during her house visit in a village of Bihar. A ASHA worker during a house visit in a village of Bihar. Whatever I'm highlighting are the key points. Came across a patient complaining of a fever and the weight loss for last 3 months. ASHA is going Bihar, village ka hai, fever, weight loss 3 months. She noticed that the skin was dark and abdomen was distended. Dark skin, abdomen distended. She performed a test called as RK39 dipstick test, which is a positive. What is the probable diagnosis? What exactly is the probable diagnosis? Okay, what is your answer? Very good. Kala azar leishmaniasis. Very good. Kala azar, that's going to be a leishmaniasis. Is that clear? Is that clear? Filariasis, that is Wucheria bancrofti and Bruggia malai. We have a test called as membrane filtration test over there. Teniasis, that is Tinea solium and Tinea saginata. Leprosy, Mycobacterium leprae, having a test, lepramin test. Okay, that is different. So the Asha is going to the village of Bihar. She is going during her house visit in a village of Bihar. What is this house visit she is doing? This is called as active surveillance. So what is active surveillance? When a hospital person, when a medical professional person will go to the house by house and check for the disease and give the treatment. What is passive surveillance? Patient is coming to the hospital and taking the treatment. What is sentinel surveillance? That is usually for the sexually transmitted diseases. So what exactly is leishmaniasis? The agent, first of all, right? The agent is L. donovani. If it is L. donovani, that is visceral leishmaniasis. That is visceral leishmaniasis, which is also called as Kala azar. क्या बोलते हैं उसको बच्चों? काला अज़र. If I talk about L. tropica, what is L. tropica? It is a cutaneous leishmaniasis. It causes a cutaneous leishmaniasis. Cutaneous leishmaniasis. If I talk about L. brasiliensis, that causes mucocutaneous leishmaniasis. that causes mucocutaneous leishmaniasis. Okay, if I talk about a vector, again a NEET PG PYQ, vector is called, what is a vector for leishmaniasis? Sand fly. But options में क्या लिखा था? Phlebotomous fly. Phlebotomous fly. Okay, reservoir are the wild animals. Reservoir for leishmaniasis is going to be wild animals. So how to diagnose this? Remember the test. Remember the test. What is the first test? The initial test for the diagnosis, that is going to be RK39 dipstick test. Remember the name of the test, that is going to be RK39 dipstick test. And this is the initial test for diagnosis. This is the initial test for diagnosis. And what is this test for? To detect the antibody detection in urine and blood. Antibody detection in urine and blood. Is that clear? Antibody detection in urine and blood. All clear? Yes. Next test, we have a bodies called as, we have a intracytoplasmic inclusion bodies. What are the bodies called as? LD bodies. What are the bodies? Leishmania Donovan bodies. We have a bodies called as Leishmania Donovan bodies. What are these bodies? They are intracytoplasmic inclusion bodies, and they are confirmatory test. The intracytoplasmic inclusion bodies seen in the leishmaniasis are the LD bodies, Leishmania Donovan bodies, and they are the confirmatory test. Okay, then the third one is going to be the Leishmania test. Leishmania test. And this test, it is not a diagnostic test. The third one, it's not a diagnostic test, and it is a just the immune status of the patient. Okay, it is not the diagnostic test, right? Immune status of a patient. Okay, not for diagnosis. It is not for diagnosis. Okay, so what is a drug of choice? You already know. Write down in the comment section what is a drug of choice. What will be the drug of choice for Kala Azar leishmaniasis? What is the drug of choice? What is the drug of choice? The drug of choice is going to be L-amphotericin B. Very good. What are the other conditions? You will give liposomal amphotericin B. Yes. What are the other conditions? You will give L-amphotericin B, LAMB, as a drug of choice. Second drug of choice is called as miltifosin. We also use a drug miltifosin, M-I-L-T-I-F-O-S-I-N-E, miltifosin. That is a drug of choice for post-Kala Azar dermal leishmaniasis, PKDL. It is also for mucormycosis. Very good. Miltifosin मैं यहाँ पे लिखता हूँ, miltifosin PKDL, post Kala Azar dermal leishman, and you can control the vector with the insecticide. Yes, very good. So it can be used miltifosin. Very good. PKDL के लिए drug of choice है that. Okay, so LAMB can be used in mucormycosis. It can be used in a cryptococcal meningitis, and it can be used in case of a Kala Azar leishmaniasis. Is that clear to everyone? So that was all about the leishmaniasis. Remember this important, my dear students. This is again the important one, vector that has been asked in your exams, in the recent exams, vector. And remember the drug of choice. Remember the RK39 dipstick test and the LD bodies. Is that clear? Yes, that I will be taking in the part 2. All all the conditions, all the diseases, their agents and their vectors we'll discuss in the one PDF. Dichlorodimethyl trichloroethane for 3 months, DDT. Is that clear? Now let's move to the next question. Is that clear? Chalo. The upper class score in the Kuppo-Swamy scale. The upper class score in the Kuppo-Swamy scale is. What is an upper class score in a Kuppo-Swamy scale? Yes, write down in the answers. Usually they ask what are the components of the Kuppo-Swamy scale, but remember the upper class score. Yes, I will take the part 2 as well. We'll see about the availability. Yes, the answer is going to be 26, 29. Now what exactly is a Kuppo-Swamy scale? Okay, this Kuppo-Swamy scale, it tells us about the socio-economic status of urban areas. It tells us the socio-economic status of urban areas. Now sir, this Kuppo-Swamy scale has parameters. What are the parameters of this Kuppo-Swamy scale? Number first one is going to be income. Number second one is going to be the occupation of head of the family. Occupation. Third one is going to be education. So income, occupation and education are the three components for the Kuppo-Swamy scale. They are the three components for the Kuppo-Swamy scale. Now if we talk about the score, the total score कितना है? 29. Total score is 29. The upper score is 26 to 29. Okay, the upper middle is going to be 16 to 25. Next, the lower middle that's going to be 11 to 15. Lower middle 11 to 15. Upper lower that is going to be 5 to 10. That's going to be 5 to 10. And next one is going to be lower, that's going to be 0 to 4. Is that clear? So this is all about the modified Kuppo-Swamy scale. That's all about the modified Kuppo-Swamy scale. So the upper 26 to 29. Your answer is going to be 26 to 29. Is that clear? So what are the components, bacho? So we have income, we have occupation and we have education. We have income, occupation and education. Okay, so this was the part 1. Yes sir, Uday Prakash scale. Yes, that is in rural areas. Okay, we have Jalota scale as well. Okay, we have Uday Parikh scale, we have Radukar scale. Is that clear, Mohammed Ansh? But mainly they asked from the modified Kuppo-Swamy scale only. We have Jalota scale as well in the urban areas. Okay, we have Shirpurkar scale as well in the rural areas. But you remember the Kuppo-Swamy scale. Is that clear? We have one more scale, modified Prasad scale. Chalo. Now this was all about the part 1. Let's have a quick recap of what all topics we have studied together. Have a quick revision. Okay, then we'll take the part 2 very soon. Okay, keep answering. So we started with our first chapter today. We started our first topic today with the pneumoconiosis. Okay, the most common pneumoconiosis is going to be the silicosis. We have discussed that it's the most common type. It's associated with the silica dust. It is associated with a silica dust. What is the silica dust associated? stone dust or the bauxite miners. The patient of a silicosis is more prone to the tuberculosis, so you have to go for follow-up for the TB. We have eggshell calcification on the chest x-ray, and we have ground glass appearance or snowstorm appearance as well. Followed by that, we discussed that the popcorn calcification. The popcorn calcification is seen in which on chest x-ray in case of a pulmonary hematoma. Chest x-ray पे कहाँ मिलती है? Pulmonary hematoma. Okay. And popcorn calcification on mammography. Popcorn calcification on the mammography, that's going to be fibroadenoma. That's going to be fibroadenoma. Remember, asbestosis, it's associated with the shipyard industry. It's exposure to the asbestos dust. It is the only pneumoconiosis associated with the malignancy. The bodies, Ferguson bodies, are the guitar-shaped bodies, are seen in asbestosis, asbestos bodies. Most common malignancy is going to be adenocarcinoma of the lung, and the most specific is going to be mesothelioma. Some of my bodies are seen also in PSM, papillary thyroid cancer, serous cyst adenoma, meningioma, mesothelioma. Anthracosis, remember, coal dust, remember, if it is associated with the rheumatoid arthritis as well, that's going to be Kaplan syndrome or rheumatonemoconiosis. Bagassosis, sugarcane dust, prevent by 2% propionic acid. Bisonosis, cotton dust. Grain husk is farmer's lung. Iron is siderosis. Bird tropics is bird fancier lung. Airspace industry is berylliosis. Followed by that, remember the vaccines given at birth is Bob, BCG, OPV and Hep B. Delayed vaccination that can be given up to 1 year is BCG, IPV, Rota vaccine, pentavalent first dose, and pneumococcal vaccine. Pentavalent second and third dose can be given up to 7 years, and OPV, MMR can be given up to 5 years. Strains of the vaccines you already remember. BCG for Danish 1331, yellow fever is 17D, Japanese encephalitis live is SA 11442, killed is Nakayama, Rota vaccine, influenza, measles, mumps, rubella, IPV and OPV. Diluents, the vaccines, they don't need a diluent, they are in the liquid form, is DPT, Hep B and tetanus toxoid. Normal saline is going to be BCG, yellow fever and dengue. Phosphate saline buffer for the Japanese encephalitis, and normal sterile water or the distilled water for MR. Remember, paralysis is a side effect of an OPV vaccine. Hypersensitivity reaction and the shock is hepatitis B. Toxic shock syndrome is going to be measles. GBS, killed influenza. Intersusception is Rota. Febrile seizures is measles. Axillary lymphadenitis, BCG. Thrombocytopenia, MMR and Hep B. Persistent crime with the pertussis. Mission Indradhanush was launched in 25th of December 2014, and it was aimed that we should coverage 100% by 2020. 7 vaccines in the beginning, followed by 4 and then 2 vaccines. Okay, then we discuss about the food adulteration diseases, lathyrism with the boa, epidemic dropsy with the sanguine, endemic ascites, pyrrolizidine, aflatoxicosis, aflatoxin, ergotism, ergot alkaloid. Patient have an osteoparalysis or the neuroparalysis, you mark the lathyrism. Patient having a bilateral edema along with the cardiac failure, you mark epidemic dropsy. Jaundice and ascites, endemic ascites, vasospasm gangrene, ergotism. This is a classical picture. Have patient taking a what? Taking the yellow pulse, having lathyrism. Okay. After that, urethral discharge, anorectal discharge and cervical with grey, vaginal with green, non-herpetic responding to penicillin with 3, genital ulcers, non-herpetic resistant to penicillin with 4, blue, herpetic with 5, red, lower abdominal pain with yellow, and black with the inflamed lymph nodes. Followed by that, the cancers that will be increased with OCPs are going to be HCB, hepatic, cervical and breast cancers. Decrease will be endometrial, ovarian and uterine. The drug that will increase the endometrial cancer chances is going to be tamoxifen, belongs to the class of the drug selective estrogen receptor modulator. Contraindication we have discussed. Followed by that, we discuss about the absolute contraindications of the intrauterine contraceptive devices. We are going to have suspected pregnancy, current PID, undiagnosed bleeding per vaginal, and the history of ectopic pregnancy, and relative contraindications like anemia, fibroid, history of PID, malformation of the uterus, or the history of multiple partners. Okay, now if a patient complains of a heavy bleeding after the IUCD, it's a menorrhagia, your management should be reassurance plus folic acid. If a patient will complaining of the pain, that means infection is there, you remove the IUCD, start the antibiotics. If there is a failure of IUCD, that means pregnancy with IUCD in situ, you remove the IUCD. IUCD outside the uterus, go with the laparoscopy. IUCD inside the uterus, go with the hysteroscopy. The classical picture of a IUCD, which is a second generation copper containing 380A, having a lifespan of 10 years. If I talk about progesterone containing IUCD, hormonal IUCD, that's going to be third generation, and the answer is Mirena, lifespan of 5 years. ठीक है. उसके बाद physical quality of life index, we have quality of life indicators, we have PQ, LI and HDI. Life expectancy at 1 year of age along with the literacy rate and infant mortality rate is the PQ, LI. Life expectancy at birth, sorry, write it here, life expectancy at birth, life expectancy at birth, that's going to be knowledge income, that's going to be the human developmental index. Okay, range is 0 to 1. Then the leishmaniasis, we already have discussed that agent L. donovani, visceral leishmaniasis, L. tropica, cutaneous, L. prazolensis, mucocutaneous. Vector is phlobotomous fly or the sand fly. Test is RK39 dipstick test or the LD bodies are seen, leishmania donovani bodies. Then drug of choice is L. amphotericin B. Upper class of Kuppuswamy scale is 26 to 29. The parameters are income, occupation and education, and total score of 29. That was all about today. I'll see you in the part 2. Till then, keep revising. Okay, solve the questions, revise your notes, check the PYQs. Most important are previous year topics. Is that clear? Okay, and meanwhile, if you have any doubts, you guys can ping me on the Telegram, but your texts should be only study related. Okay, all clear, guys? Write down in the comment section. After this, we'll be soon having the pathology and I will take pediatrics. Okay, OB-GYN part 3, yes, I will. No problem, you can watch the video later with Kalp. Thank you. All clear? Yes. So we'll soon have some more. Yes, we'll have soon some more sessions, and what you have to do, keep revising your notes, and I will try to take more parts for PSM and OB-GYN because they are scoring subjects and the big subjects. So till then, you keep revising your notes, solve GTs and run your own race. Don't compare your knowledge with anyone, and we got this. Okay, we are going closer. You might be anxious, nervous, but it's normal before the exams. So I hope session was interactive enough. Yes, PDF you'll get in. I'll send to the Meduhub management. They will forward in your main channel. Okay. So good luck, guys. I'll see you.